Good morning, everyone. My name's Lesley Maclennan. I'm one of the diabetes specialist midwives at Counties Manukau. So I'm going to be talking specifically around our Counties Manukau situation. And Sue's also asked me to mention a little bit about pre-pregnancy care. So hopefully you'll have time at the end. I'll just talk a little bit about that. So to put in perspective for those of you who are not working in our area, Counties Manukau currently has around 34,000 people living with diabetes. And as we know, many diagnoses of diabetes haven't happened yet, so we know there are lots of people who haven't been diagnosed yet. Our population is got large amounts of Maori Pacific and increasingly Asian. We have a young population. They are having lots of babies, and about a third of our population are under the age of 15 years, so they're going to continue to have lots of babies. We also have an area of high socio-economic deprivation, with a third of our our population living in quintiles 3, 4 and 5. And we know from lots and lots of studies, all of those factors contribute to higher incidence of diabetes, obesity. And there's an actual study, an article was published in the New Zealand Medical Journal just this June this year about geography in relation to diabetes in Auckland. And we know that you are 60% more likely to have diabetes if you live in southwest Auckland than if you live in the North Shore. And our population is also growing, so we estimate about 561,000 people living in our area by 2020. So to put that into perspective for our birthing population, this is women birthing at Counties Manukau identified having diabetes in pregnancy, and you can see that our incidence of diabetes in pregnancy has risen from 3% in 2006 to 8% in 2015. And of significant interest is, although our Pacific and Maori populations are quite stable, we've got huge growth in our Indian, Asian and Chinese population. So we know, again, that's a group that have higher incidence of diabetes. So I'm sure you are all familiar with the Ministry of Health guideline. We've already mentioned this. It was released in December 2014, the week before Christmas, as anything that is controversial does happen in the ministry. If you would like to, this is the document that came along with the ministry guidelines. So if you haven't had time to read that yet, there is actually a BPAC guide that actually summarises the ministry guideline in the context of general practice. It's a really excellent little resource. So to put it in a nutshell, counties, going back to our slides where we know that we've got huge amounts of diabetes and we've got huge risk of diabetes in pregnancy, we decided that we would take on the ministry guideline as it is. So we have adopted from July 2015 what it says in the ministry guideline. So we've already talked about women who should be offered, every pregnant woman offered an HbA1c before 20 weeks ideally with their booking bloods. And the rationale behind the ministry guideline is to try and detect those people who already have diabetes, but because they're young, healthy women, they might not have had a test for diabetes prior to becoming pregnant. So we want to identify women who have an HbA1c greater than 50 because they have, according to NZSSD criteria, got diabetes. And we would get them referred directly to our diabetes and pregnancy service. The controversial group are the group of women who have an HbA1c between 41 and 49. Now, as you all know, if you had a patient who came and had an HbA1c of that level, you would go off and tell them to make some changes to their diet and lifestyle and come back and see you in 6 months and recheck their HbA1c. So that's why the ministry decided that's what we should do with pregnancy as well. We can't say that those women have pre-existing diabetes prior to pregnancy, that they should go off and have some diet and lifestyle advice, but they are high risk of developing gestational diabetes, so they should have a GTT at 24 to 28 weeks. Ideally closer to 24 because it takes people a few weeks to get round to getting their GTT done. Right. There is the group of the HbA1c 41 to 49. If you look in your Auckland Regional Health Pathway, the action that it tells you for that group is quite different to what we have at counties. There are 2 DHBs in New Zealand who are looking into whether or not that group of women should have additional care and whether that makes a difference to the outcome for that mother and baby. And that's the Pinto trial. So I'm going to mention a few research studies as we're going along. So if you are living in the Auckland District Health Board region or Canterbury, then the Pinto trial is available in those two areas. Sue already showed you the healthy weight gain and pregnancy package. So that's a little tear-off booklet, tear-off sheet that you can order from the ministry. It also comes with this healthy weight gain and pregnancy guide for women with the information that you need to tell them about their diet and lifestyle. So this isn't suddenly we all have to become dietitians so that we can tell these women what the dietary advice they have to have. It's actually on this sheet of paper. The weight gain and pregnancy one is also a little controversial. This is the Institute of Medicine guidelines, which is international. There is some discussion that for Australia and New Zealand this isn't suitable, and in fact that it should be tighter. But the main message that we give to women is about the weight that you gain in the first 20 weeks of pregnancy. That's the weight that's the most difficult to lose, and that's so you want to be gaining most of the weight that you're going to gain after 20 weeks of pregnancy. So if once you've screened to make sure that that woman doesn't have pre-existing diabetes, then we still need to test for gestational diabetes, and that practice hasn't changed. So screening for gestational diabetes is in a low-risk group of women, so the women who have an HbA1c less than 40, you still offer them a polycose, which is an additional screening test. If their polycose is greater than 11, refer to diabetes services. If it's between 7.8 and 11, do a GTT. And the HbA1c group 41 to 49 should still have an oral glucose tolerance test. However, if you, in your clinical practice, still think that actually I don't think that a polycose is suitable for that woman, then absolutely you would go ahead and do a GTT. So you would use your own clinical judgment. At Counties Manukau, we have developed an algorithm, and that's available through HealthPoint. It is not on the Auckland Regional Health Pathways, and that's something that I will rectify. So the pathway includes contact numbers for all of the diabetes and pregnancy team. It also provides you with links to these resources, so you can get them from the ministry website. So I just briefly mentioned the diagnostic criteria for diabetes and pregnancy. This is another area that the ministry guideline identified that we needed to have some further research on, and that's the GEMS trial. So you may have women who have been invited to take part in the GEMS trial. The GEMS trial is looking at the current ministry guideline compared with the International Association of Diabetes and Pregnancy Study Groups, diagnostic criteria for gestational diabetes. Also at Counties Manukau, we've got the HUMBA trial, which is looking at dietary advice plus or minus probiotics for improvement of glucose metabolism, hopefully preventing GDM. And there's also the NIPPER trial, which is going on in Auckland at the moment, which is looking at a nutritional supplement pre-pregnancy. So when your woman is diagnosed with diabetes and pregnancy at Counties Manukau, we do group education sessions for the woman with a midwife and a diabetes dietitian. They have the follow-up at the multidisciplinary team. Women who've got type 1, we would meet with them individually, specifically around insulin resistance in pregnancy, what to expect, and hypoglycemia management. The dietary options and diet and exercise are the first options for diabetes and pregnancy management, and at Counties we use metformin and insulin. They're taught how to use a meter, how to record their blood sugars. We give them they're told that their blood sugars are a guide to treatment. They're not a test to see whether or not you're behaving and doing your blood sugars. They're actually a guide to tell us what treatment that you need. We also give them their targets, and we make sure that they know not to make them up. So the blood sugar targets at Counties at the moment are fasting less than or equal to 5 and a 2-hour less than or equal to 6.7. And that's because at the moment we're taking part on the Target trial, which is another trial that the ministry identified needed to happen because we're not 100% sure what are the best targets to ask women to achieve. You look at these numbers and think they're incredibly tight compared to what you'd be asking people to achieve who are not pregnant. At the moment, Counties, we're now on the tighter targets. And just follow up, so I'm just running out of time. So after the other big change that happened in the ministry guideline was we no longer have to do a 6-week GTT to check to make sure for those women with gestational diabetes that their diabetes has gone away. We now recommend an HbA1c at 3 months. That falls outside of the midwife's scope of practice, so it now falls to primary care to do that HbA1c at 3 months. At counties, we tell the women about their risk of GDM in future pregnancies, that they've got a 10% chance of developing type 2 diabetes within the next 10 years. We continue to tell them to continue with the lifestyle advice they were given during the pregnancy and to see their GP for an HbA1c at 3 months. Finally, just very quickly, I just want to introduce, this is my friend Lesley and her baby. Lesley's kindly let me use this photograph of her today. She presented at 24 weeks in pregnancy, type 2 diabetes, BMI of 46. She's a smoker. She's got a history of cellulitis. She's hypertensive. She's on Lantus 60 units once a day. She's had 2 previous miscarriages in 2011, 2013. She's been seeing her general practice for lots of appointments. She actually, in fact, also had an appointment with a diabetes nurse less than 6 months ago, but she didn't present in pregnancy until 24 weeks. So this is Lesley and her baby, who was born at 29 weeks and 4 days after she developed preeclampsia. Now, she has lots of modifiable risk factors for developing preeclampsia, and my hypothesis is if she came to us early, we may have prevented that premature birth. So what we want to do at counties is we're about to embark on a pre-pregnancy project. So if anyone here from South Auckland is interested in joining us in that, we're looking for a practice or a group of practices where we will come along, a midwife and a dietitian, and we'll start a pre-pregnancy clinic for women with pre-existing diabetes prior to pregnancy.